We're now going to talk about evidence-based treatment of CSC. But when you think about evidence-based treatment, you're not only thinking about the clinical trials that have been there to show that one treatment is better than the other, and they are there now, but it's also about evidence about the cause of the disease, and that's what I would like to start with. But first, thinking about evidence, just have a think about your medical studies, that there is a hierarchy in evidence. And until not too long ago, there was a lot of retrospective evidence or retrospective studies in CSC, as in many other diseases, about so-called treatments that would be effective. But as I told you previously, the likelihood of a spontaneous improvement or resolution is quite high in CSC. So retrospective studies in CSC are very problematic, so you have to be very skeptical about that. Anyway, as I already told you, it's relatively common. And also, why should we treat? Well, of course, you can have a little weight in the acute cases, because they tend to have a spontaneous resolution. But it has been shown that there can be irreversible vision loss and a decreased quality of life in patients with chronic CSC. And if you wait very long, you can get cystoid changes, you can get atrophic RPE changes. So I think, if possible, you should try to treat before that. But I also know, of course, from clinical practice that some patients come in and they already have these horrible chronic features, which is probably because of the smoldering choroidal changes that already affect the RPE. But if possible, treat early enough. There's a highly variable preferred practice pattern around the world, but even, for instance, in Europe, there are many differences between countries. And that's a little bit difficult to understand, of course, because there are some papers out there now in trials that really can guide you, but I'm going to discuss that. So again, when regarding evidence, try to separate the hard evidence from the, let's say, questionable evidence. And here's the Vici study again, and if there's one slide you want to remember from my presentation, it's this one. And interestingly, this table was only published in the supplementary tables, and it's very difficult to find in the study, but I think it's one of the most important ones when thinking about CSC. Because here it is. It's a slide showing what the percentage of complete or partial resolution on OCT was in the patients who received placebo versus oral eplerenone treatment. Eplerenone is a mineralocorticoid receptor antagonist, which theoretically makes sense to give to CSC patients. But the question was, at one point everybody says you have to give eplerenone because it makes so much sense, and we see in some patients that the fluid goes away, but there was no prospective study. And then fortunately our great colleagues from the United Kingdom, Andrew Lotri and Shobha Sivaprasad, they said, okay, we're going to do a prospective investigator-initiated trial. And that's what they did in a multi-center setting. And they compared placebo to eplerenone, and have a look at this. After 12 months, a complete resolution of subretinal fluid was seen in 30%, as I already told you, 30% of the placebo-treated patients, and only 16% of the eplerenone patients. And the funny thing is, so the authors, of course, concluded, okay, there is no place for eplerenone as a first-line treatment of CSC because it simply doesn't seem to work in chronic CSC. But still, there was discussion that it might still be a good first-line treatment, which I think is mind-boggling, but anyway. We need prospective randomized controlled trials, that's for sure. But thinking about treatment, I'm going back to the pathogenesis first, because as already what passed a bit in the first presentation, there is a problem with the equilibrium between the choroid and the RPE. So there's a problem between the retinal-choroidal interaction, because there is a dilation and choroidal flow problem because of a choroidal congestion. So the large choroidal vessels are enlarged, which is the pachychoroid, pachyvessel idea. And secondarily, the choriocapillaris, as you can see here, is thinned because of the thick vessels below it. And subsequently, there's also leakage from the choroid, hyperpermeability, and the RPE can be affected. There can be RPE detachments, and if there is a breakdown of the outer blood-retinal barrier of the RPE, there can be subretinal fluid. So there's a disequilibrium between the pumping function of the RPE that is compromised due to a problem with the choroid. So how does this choroidal problem work? Well, we're not exactly sure, because we're still not sure why so many more men are affected than women, and the genetics I'm not sure about. But what we are thinking and this was published by Rick Spade in the paper in which we also were involved, there's an outflow problem at the level of the vortex veins. And that's probably why the veins are dilated. There are also some excellent Japanese groups who have found that there is indeed venous congestion and asymmetric drainage of the veins in the eye. There are no clear watershed zones that are normally present, and there's a delayed filling and ischemia of the chora capillaris. So that all makes quite a lot of sense. And we, in a prospective study with wide field angiography combined with central angiography with Heidelberg, we looked with Laurens Palaikov, a PhD student who was in Amsterdam for a year. We looked at these venous overload choroidopathy signs. And interestingly, also something that I noticed in the clinic, what is very common in really typical CSC, if you have differentiated it from other diseases, is the mid-phase indistinct hyperfluorescence. And actually we found that this was the most common sign that we found in this cohort. So not only were these these venous overload signs of Pecci vessels and anastomosis common, but the leakage, the hyperpermeability, as you can see here, but it's better seen actually on for instance, spectralis imaging, they are really common and they seem to be almost pathognomonic for CSC. So some really nice studies from the Japanese groups also found that there is an increased scleral thickness that is associated and correlated with the choroidal thickness in CSC. So there also seems to be a scleral problem in CSC. And the group from Paris has also shown that there are quite some patients, and that's also my experience, that have choroidal folds. And in my experience, the patients who also have choroidal folds tend to be the more severe ones that might not respond to PDT as well. And we postulated that there might also be a role for arteriovenous anastomosis even. So here you see, for instance, a pulsating vessel of arteriole that drains into a venule. This needs more proof, I must immediately admit, but there also may be a role for anastomosis within the back of the eye. All to say that choroidal vascular congestion and leakage are key features when it comes to this pathogenesis of CSC and are therefore, of course, an important target for treatment if you can treat it. As Susanna already alluded to, the differential diagnosis can be very tricky. So if you want to have a look at this paper, it will take you some time. It's because it's like 85 pages or so. But this really gives you an overview of all the sometimes very rare and sometimes very dangerous, as Susanne said, differential diagnosis. It's available for free. If you scan the QR code, you can look it up. So now let's go to the evidence for treatment. And first of all, I think it's important to discuss with you what should be the aims of the treatment. Well, this is also a bit variable between people, but I simply think you have to get rid of all the subretinal fluid, like in this patient who received PDT. And this will take time to improve the visual quality because, as you can see here, the ellipsoid zone is still quite blurry because the photoreceptors that have been chronically detached, they have to get back on their RPE, and then all these outer photoreceptor segments, they have to be eaten again by the RPE. But with time, if you're not too late with treatment, this can reconstitute and patients can really say, okay, my quality of vision is really improving, such as in this case. So you want to get those photoreceptors back into the RPE. But what you also would like, of course, is to reduce the risk of recurrences in CSC. And this is why you have to treat, I think, the underlying primary problem, which is the choroid. This is actually the same patient, can you believe that? So this is only very little RPE changes, but there's a very extensive abnormality of the choroid. When evaluating efficacy, many of the studies that have been published are relatively problematic because of being retrospective, being variable in their definitions and inclusion criteria. The classification is still a bit controversial, so yeah, be aware of the studies. But when thinking about the treatment options in chronic CSC, these, I think, are the main ones that have been advocated. Photodynamic therapy is first and foremost a treatment that you can consider if you have access to it, of course. The idea being that, of course, it was developed for AMD, but it also seems to have a remodeling and quieting down effect on the choroid. So you have this big, thick, leaking choroid, and if you use PDT, you can really get this choroid a bit back to the normal situation, less leaky. And what was found that not only the full settings PDT is effective and also quite safe based on the studies that are there with 4 years of follow-up, but half dose or half fluence or half time can be equally effective and maybe even safer. Then micropulse laser treatment, which is of course theoretically extremely attractive because, well, you might not be doing much to the retina. So you have these tiny pulses that are separated by a pause. You don't see a visible endpoint, which is also a bit of a problem actually. And we're not actually sure how it works. It was supposed to trigger the RPE to let it pump more fluid away, but it doesn't do anything to the choroid, which is the primary problem. But if it works, it will be really great. But there's not too much evidence out there, and I'm going to show you. Conventional laser treatment, there are only older studies on that, but that can be quite helpful with eccentric leaks, and if you don't have access to PDT, you can laser the leak. But the problem there is that you can, of course, cause scotoma. It can become a weaker spot also for CNV development. Anti-VEGF treatment in uncomplicated CSC has been found to be inferior to, for instance, PDT, but it can, of course, be helpful when there is a CNV in CSC. The problem with CNVs in CSC is that they can also be relatively inactive. So the CSC component can be much more important than the CNV component, but it's difficult to tell. And it's often quite a small, flat type 1 CNV. But if you're in doubt, I would definitely recommend to try some anti-VEGF, maybe in combination with PDT. And then the mineralocorticoid receptor antagonist, there's only one really good prospective trial published in the Lancet, and I already discussed it with you, which was the Vichy trial, and that clearly showed that it was not better than placebo. So what about PDT versus micropulse laser treatment? Well, in the PLACE trial, which was the first large prospective randomized controlled trial in CSC, we performed an investigator-initiated study in the Netherlands in 3 academic centers in which we performed ICGA-guided treatment of CSC, chronic CSC, and we found that there was a clear superiority of PDT over micropulse laser treatment. I have to give you one caveat. The percentages of success that you see with PDT might strike you as a little bit lower than published in literature and also subsequent studies, and this is probably because it was just before the OCTA really came up. So we might have had a few patients who had also a type 1 CNV together with CSC, because in subsequent studies the percentage was a bit higher, but it certainly was superior over micropulse laser treatment, 810 nanometer micropulse laser treatment. And also functionally there was a benefit in favor of PDT. So we found that PDT is more effective than micropulse laser treatment in chronic CSC, both with regard to resolution of fluid and with regard to functional parameters. This was published in Ophthalmology in 2018. And we also found that it didn't matter if you had focal leakage or diffuse leakage on FFA. And what we also found was that in the patients who first were randomized to micropulse laser treatment and didn't respond, they did respond very effectively to PDT, but this was not the other way around. The Vichy trial I've mentioned several times now. No place for eplerenone as a primary treatment. And what we did in a subsequent prospective randomized controlled trial in the Netherlands, together with Suzanne in Nijmegen and in Amsterdam and Leiden, we compared half dose PDT to eplerenone. So it was like the logical next step when thinking about the Vichy trial. And here we again, as expected, I must say, we found that PDT was markedly superior over eplerenone. And look at the percentage in eplerenone. So I told you about the 16% complete resolution after 12 months in Vichy. Well, actually we found 17% in the eplerenone group, so it's almost identical. And there was also functional benefit in favor of PDT. So in summary, when it comes to the good evidence that is out there, it's important to look at large prospective randomized controlled trials with good inclusion criteria. The PLACE trial found that PDT is superior over micropulse laser. Vichy found that eplerenone is superior over placebo. And SPECTRA found that half-dose PDT is superior over eplerenone. And very recently, this is really fresh from the press, we published with an international group of experts on CSC an evidence-based treatment guideline in proximal retinal eye research, which is available for free open access, and you can scan the QR code, in which we give a very extensive overview of the pathogenesis and the evidence that is out there, in which we also provide a flow chart with regard to our recommended acute CSC management, but also chronic CSC management, as you can see here. So in the last 2 minutes, I would like to take you to why PDT works best at present. Well, you can already guess it is a more direct and rapid treatment of the primary underlying problem, which is the choroid. It is more effective in getting rid of the fluid rapidly. It really has a very fast effect on the choroid, and it also leads to less recurrences, which you would also like, of course, which we published in 2021. I don't have any financial links to Visudyne or PDT, by the way. But it's not a miracle treatment. So the effectivity rates are somewhere between, let's say, 75 and 85, 90%. But especially these more severe, long-standing cases, they can be difficult to treat with PDT, and then you're in trouble, because in my experience, it's very difficult to treat them then. And then finally, and this is a question that I get very often, because many colleagues don't have a lot of experience with PDT yet. We've treated thousands of patients in the Netherlands now with long-term follow-up, and we're also publishing the 5-year follow-up data, Suzanne and I, in the coming year. Is it safe, PDT? Because people remember, especially older colleagues remember, that sometimes you could have ischemia in full dose PDT in AMD, but just remember that AMD is a completely different disease from CSC. And we're using half dose or half fluence, by the way. But you have to check the facts and the data, right? So that's what we did in the PLACE and SPECTRA trial. We looked at patients who had fovea involving half-dose PDT, so the spot included the fovea, because that's also a question that people ask, can you treat the fovea? That's not a problem at all. We looked at these data with 2 years of follow-up, with the typical settings in the lower left. And what we found that in all of these patients, there was a marked improvement of the outer retina and also of function, and none of the patients developed any atrophy of the ellipsoid zone, of the ELM, and also the RP, both on OCT and on FAF. So you can be confident about that, because you really wouldn't like to damage the macula in patients with a relatively good visual acuity like CSC. But there's no need to worry about that, even on long-term follow-up. So in conclusion, PDT in chronic CSC is effective and safe. Observation should be, I think, the preferred approach in first episode acute CSC, but you can consider early treatment, for instance, in patients that are professionally reliant on a rapid resolution, pilots, bus drivers, etc., doctors. PDT primarily treats the choroidal abnormalities and therefore is probably most effective. Think about it, broad differential diagnosis, because it can be tricky. And finally, definitely we need more treatment options, because in my experience, PDT is the only really effective option, and if it doesn't work, you're in trouble. Thank you very much.
So thank you.